today I would like to introduce to you a friend, a very good friend, Dr. Ken Mautner. And I should see he's been here. How many times, Dr. Ken? 3 times, right? You've been here 3 times.
Twice I've been there. Two
Oh,
times.
twice.
Just two
Okay.
so far. Yeah.
And the volcano you were visiting, the volcano you visited,
Yes.
erupted.
Yep. Before it erupted, right?
Yeah.
Yeah.
So it's good that you were able to see them before it erupts, because right now it's completely destroyed. I mean, there's
Oh
no way
wow.
you can go there because everything was covered with ash.
Wow.
So it's very scary to go there. Although the ashes is already gone from in those places which initially covered it, but the volcano itself around it, it's really full of ashes. Yeah,
Wow.
yeah. So it's good that you saw it before it happened. So
Is it
right
gonna
now we
ever?
have,
Yeah. Go
yeah.
ahead.
Go ahead.
No, I
Yeah,
was gonna ask you if it is. Will you ever be able to walk on it again, or is it totally covered for good? The
yeah.
volcano.
Totally covered for good. So there's no way
Oh.
you can really walk there. It's all ashes. It's all ashes. So good morning from the Philippines. Good morning to all of you. I would like to introduce to you today a good friend of mine, Dr. Ken Mautner from Emory University. He's working in Emory. As you can see, he has a lot of qualifications here. I will just read a few of them so you will know exactly uh, the details of the things that Dr. Ken is doing, and he'll be sharing to us a lot of other things today. He's an associate professor of Emory Sports Medicine. He's the head team physician of Atlanta Hawks. He's a team physician of Atlanta Braves, so he's really got into this sports thing. He's the director of primary care, sports medicine, yeah, and of course, a fellowship director of primary sports medicine. So he's going to talk about regenerative medicine. I'm sure with ultrasound all the time. He's been a speaker in so many conferences, also in Toby this weekend. So if you want to watch Toby, Dr. Ken would be there as well. So today, I just would like to welcome everyone before I turn over this to Dr. Ken, and I hope everybody is settled. And before we begin, let us just pause for a moment. We'll just have a short prayer. Let's just pray first, and then we will proceed. Let's bow our heads for prayer. Heavenly Father, we entrust our lives unto you today. You have been so good to us. You have given us life and strength. You have preserved our lives, our families. And up to this moment, you have been always been good to us. Heavenly Father, we trust Dr. Ken Mautner, who will be sharing his experience, his knowledge on regenerative medicine and ultrasound. Can guide him, oh God, and guide the rest of us who's going to learn from him, and forgive us, oh God, from the sins that we have committed against thee. In Jesus' name we pray. Amen. So, welcome everyone. And I'm going to turn over the hosting to Dr. Mautner so that he can control uh, everything. Dr. Ken, the floor is yours.
Thank you. Well, thanks for coming out in the morning. It's 9 o'clock at night here. I appreciate everyone tuning into this lecture. Um, let me just get my screen up here. My screen share clip. That should be good. To share your computer, please install. Oh, shoot. Okay. Can you all see that, Jim? Are we good? Y'all can see that?
Yes.
Okay, thank you. All right, so let me just get my first screen up here. So once again, I've been to the Philippines twice to see many of you all, and it's been some of the best trips I've ever been on with my good friend and colleague John Finoff, and Jim had already talked to us about coming back for a third time, or at least talking about when that next time will be, and who knows now with everything we've been through, but it was good to be able to connect with y'all and see you all, and I look forward to this lecture, because I just I can't say enough good things about the way y'all have treated me every time I've been there. So my plan here, I'm going to talk about orthobiologics and regenerative medicine here. My plan here is to probably talk for about an hour, and following that, we'll have some time for Q&A. I don't have my chat feature up right now while I'm talking, so if you write, you can send me questions via the chat. I can get to when we're done. But if you want to stop me to ask for anything during the talk, just kind of unmute yourself and you can, just ask the question. I'm totally fine with that. If not, we'll just do it at the end. So, and this is the picture from last time I was there a couple of years ago. So I'm sure some of y'all are on here right now, and it's great to be able to talk to you all. And once again, I do look forward to coming back in the future once all this madness is behind us, and we can all safely, visit each other in person much better than this whole Zoom thing we're doing. So the title of my talk is evolution of orthobiologic injections in sports medicine, from patient zero to the Holy Grail. It's going to kind of take you through my 12 or 13 years of doing these procedures and kind of how the field has evolved, how I have evolved, how some of the research is going, and kind of what we have to look forward to in the future. I do have a couple of disclosures here, but nothing that's really relevant to my talk today. So, when you think about what is regenerative medicine, what are orthobiologic injections, where are you trying to go with this? It's really a mixture of what we call precision medicine. So we want to get an accurate diagnosis. We want to have the correct use of the correct orthobiologic. We want to have accurate image guiding for precise therapeutic delivery. And the goal is with these things that we can have a potential for shifting the paradigm in orthopedic care. So what we're talking about is rather than kind of disease modification, rather than just symptom management. And that's why I got into this whole field to begin with many years ago, was that as opposed to just managing diseases, I wanted to be able to modify and change the course of people's health for the better. So if you look at the evolution of orthobiologic injections, this really started back in 1350 BC. They did pin firing, meaning hot pins that they would put into different areas to help stabilize joints and these kind of things. Hippocrates was using similar things as well. So these are like ancient sclerosing type of agents. And then the start of all this was prolotherapy, which was first described in the 1930s. So prolotherapy, which many of you probably know the term, has been around for about 90 years now. In 50s and 70s, a couple of doctors, Hackett and Hemwall, really became the fathers and the grandfathers of prolotherapy, where they were treating a lot of ligamentous laxity using anywhere from 12.5 to 25% dextrose solution. So the mechanism of action is that the dextrose stimulates proliferation of growth factors, which helps to promote healing in the ligament, tendon, and cartilage. There's also an osmotic effect on local cells by the fact that you have this hypertonic solution that you're injecting into the area, and you get this inflammatory response, which leads you down the healing cascade. In addition, just the needling itself can create a little localized bleeding and trauma, increase blood flow to the area. Once again, take you down that healing cascade. And there's plenty of evidence showing that dextrose itself can have analgesic effects. And so if you think about it, prolotherapy has multiple mechanisms by which we think it is successful, and why it is still used today in a lot of settings. So once the ultrasound machine came into vogue, initially it was these portable machines like you can kind of see on the right here, and then we had the ability to take what was an office procedure, which was a tendinotomy, say for a chronic tendon, and by repetitively needling that tendon, even without dextrose, we found that we could induce inflammation and release growth factor, which then can lead to healing of these tendons. And so in the mid-2000s, when ultrasound kind of came into more everyday kind of use, people started doing what they used to be the surgical tenotomy and doing percutaneous needle tenotomies. So the first study on this was put out by 2006 by Lev Nazarian, who many of y'all may know. He's a really good ultrasonographer from Pennsylvania and Philadelphia, and John McShane as well. And basically, they took a bunch of patients, did a retrospective study. They had 58 patients, and all of them, they've given an ultrasound guided needle tenotomy with the steroid injection for chronic tendon condylitis. And they had 80% good or excellent outcomes, and 85% would refer a friend for the procedure. So then they did the same study and published it 2 years later, but they took out the steroid because if you're needling a tendon and trying to induce a healing response, you can rationalize why steroid may actually be harmful to that. And they actually found better results. 92% had good or excellent outcome, 90% for a friend. And this, even though it was just a retrospective case here, it became the landmark study that started down this road of doing needle tenotomies. Now, around the same time, in 2006, the first study on platelet-rich plasma in humans really came out by Alan Mishra, who's a Stanford-associated orthopedic surgeon. And he looked at 140 patients who had really bad lateral epicondylosis and found 20 of the most refractory cases who had had at least 15 months of symptoms. And he put 15 in the treatment group and 5 in the control group, and basically given them one PRP injection into the common eccentric tendon, followed by 4 weeks of rehabilitation. And what he found was that if you looked at folks at 1, 2, and 6 months after treatment, 46, 60, and 80% improvement in pain scores. And so these are important numbers because it tells you a few things. Number one is, after a 1 month and a 2 month, there's an improvement in people who do better. And then by 6 months, that improvement keeps on going. So, PRP, as we'll talk about, doesn't work very quickly. And even at 6 months with that 81% improvement, but at the final follow-up, which is about a year to 3 years after the study, 93% were pain-free, no complication, no one got worse. This, in essence, what the safety study did, a very small numbers, and it proved safety, but they also proved very good efficacy. And 3 out of the 5 people in the control group came out of the study and saw other treatment. So what is PRP? Well, the simple definition of PRP is semi-autologous concentration of platelets in a small volume of plasma. So anytime your platelets is higher than your baseline platelet count, you have platelet-rich plasma. So it's a huge variability what that can mean, from something that's 1.5x to something that's 10x times your baseline blood concentration. But inside of your growth factors, your platelets have growth factors inside, which are secreted by alpha granules. Inside amongst these growth factors are all these different ones. Platelet-derived growth factor, transformer growth factor, VEGF, vascular endothelial growth factor. And you can see that all these different growth factors, when mixed together, kind of form a soup that helps to lead the healing of tissue. So if you cut yourself with these growth factors that are released from the platelets after the clot is formed, that will eventually heal your skin and heal the injury. So if you look at the history of PRP, the term was coined in the 70s. Originally, it was used for transfusion when they were trying to save blood and prevent clotting in surgeries. It wasn't used really in the surgical realm or in the orthopedic realm until the early 2000s. It was used with some horse orthopedics before that, and really in humans, maxillofacial surgery was some of the first uses of this as well. And sports medicine, kind of came a little bit after that, and then peripheral nerve repair, which I know Dr. Jim does a lot of, even later. So this is kind of the history of when different fields kind of started adopting PRP. So how does it work? Well, so in soft tissue and tendons, I'll tell you that it works differently in the soft tissue than it does with cartilage and inside of the joint. I'll talk about that. But first, we're going to talk about tendons and soft tissues, right? So you do an ultrasound guided injection. This is showing a supraspinatus tendon. You're not coming in. We're injecting a biologic into the tendon, just filling in the defect. Once that happens, these platelets are activated. They release their growth factors, and these growth factors initiate this healing cascade. First phase, inflammation, lasts a few days. Second phase, you get this kind of granulation tissue. Third phase, you get wound contraction, and eventually you get this maturation phase. And if you look at the time here, this goes on for 3 months, 6 months. It goes on for quite a while until you get this total healing to occur. So the perfect storm for clinical application of PRP in musculoskeletal injuries. And so as I mentioned, there was a rapid growth of ultrasound use in musculoskeletal medicine in the mid-2000s. We had a product that was really easy to obtain platelets. You don't need to go to the OR, you don't need a surgery center. We had a problem, which was tendinopathy, which didn't have a good solution. Right? Chronic tendinopathy is how PRP came to be. in my clinic because surgery, rehab, all the things we do for these chronic tendons don't always work that well, so we need a different solution. This is also the same time we started showing studies, which I'll get to in a minute, demonstrating the toxic effect of corticosteroids on tendon, which have been the mainstay treatment for decades for tendinopathy. Plus, in my practice, we had a motivated patient population that will do anything to get back sooner and to get back stronger. And we have these early studies, like I mentioned before, we showed remarkable success in the ability to kind of fix an injury. And honestly, if you look at all that, you'd say, well, what's the downside? So all this is well and good, but it was really kind of what I call, the Heinz Ward effect, which if you don't know Heinz Ward, he was an NFL football player in February 2009. They played in the Super Bowl, and 3 weeks before the game, he injured an MCL in the NFC Championship game. Sorry, two weeks before the AFC Championship game. And on the sideline of the Super Bowl, the reporter gets up there and says, "Heinz Ward done this experimental PRP treatment." 2 weeks later, he's playing the Super Bowl. We all know PRP doesn't work in 2 weeks, but this is how the story came to be, and how legends are born. So following this, there are multiple articles about these treatments from famous athletes, like Tiger Woods and other football players and baseball players. Really, in 2009, this kind of made their round, and this is how PRP kind of got started. So my patient zero with PRP was before this kind of hit the mainstream, but just by a few months. I had a 29-year-old WNBA player, that's the Women's National Basketball Association. This is her name, Nikki Teasley. She'd had chronic patellar tendinopathy for 5 years. Her teammate had gone to see Alan Mishra in Stanford, who did a PRP injection, and it worked really well. And this athlete was considered retirement due to her pain. So remember, this is ultrasound from 2008. So this was my old machine, my first GE I had. You can see her patellar tendon as opposed to a nice, hyper or fibular compact display. You can see thickening of the patellar tendon. When you look at it as short axis, not the best views here, but that's the patellar tendon. Long axis, short axis here. You can see in the middle, there's a kind of central defect in the tendon as well. So I didn't have a machine. So basically, we had a centrifuge machine, which looked a lot like this. I had this, kind of what now would be an older ultrasound machine. And I drew her blood, and I put it in the centrifuge, and I looked up how much to spin it. And then we took out what we call the Buffy coat, and we got the platelet-rich plasma out. And basically, this is actually her tendon, and I injected the PRP. And the other thing you can see is as I injected, she did have a little tear, so it up right there in her proximal patellar tendon as I injected it, and then needled the tendon at the same time. So 4 months later, interestingly, not only did she feel better, and her pain was pretty much gone within a week or two, which once again is not how PRP works, but her tendon actually looked better. It got thinner. It looked more normal. Nikki went on, radio and to news, and she was on, talking about how she thought she was going to retire. The pain was so bad she couldn't get up in the morning. After the injection, she thought she could play 5 more years, and so it was really a glowing success, and kind of got me started down this road, which is still going down. So we know with tendinopathies, the vast majority of tendinopathies are degenerative and non-inflammatory. So we used to use the word tendinitis, but we now know that studies show degenerative lesions. This has been around for a while now. If you want to really read about tendinopathy, you should read about the Comparative model of tendinopathy. This is kind of a complicated slide, but basically it says that when you have a normal tendon, normally the body wants to adapt to the load on that tendon. However, if you have excessive both intrinsic and extrinsic loads on the tendon, you get a reactive tendon. These are what we would previously have called an inflamed tendon. So if you have this reactive tendon and it's early on, if you modify the load, you can heal the tendon. If you keep going down the path, you get to the state of a tendon disrepair and a degenerative tendinopathy. And these are really hard to treat, even with rest, even with rehab type of treatments. Or if they do get better, they take a long time to. Now, the problem is a lot of times we don't know about these tendon injuries until we're already in this state, because sometimes these reactive tendons and early unhealthy tendons are asymptomatic because of our pain thresholds. And so it's a very complex model. But my point is, we're talking about these tendons here that are really degenerative and are not getting better. The first double-blind, randomized control, placebo-controlled trial on PRP came out in 2010, so about a year after the whole Super Bowl Heinz Ward effect happened, and it kind of quelled some of the early enthusiasm. Because in this study, which looked at mid-substance Achilles tendon, they injected either PRP or saline into the tendon. They rehabbed both groups. After 2 weeks, they started an eccentric exercise program, which if you don't know are kind of the negative phase of rehab, where you're kind of lowering your leg or your ankle slowly off of the table. And then they had no sports for at least 4 weeks, and then they did a follow up to 6 months out. And basically, after 6 months, they found no statistical difference between the two groups. Both groups did improve, and there were no adverse events either. So safety was proven, but efficacy was not. So a couple of things about the study. Number one, they did eccentrics on both groups. Neither group had eccentrics done before their PRP, and we know that eccentrics has a high success rate. Studies say 70 to 80%. I would say more like 50 to 60% for treating chronic tendinopathy. But so a lot of these patients would have gotten better even without any injection. Secondly, the eccentrics were done really early at 2 weeks, probably a little bit earlier than I would like to do. And both groups improved. And so we know that the other group did get a saline and a needle into their tendon, which can have a therapeutic effect on the area. And lastly, only one treatment was done. And we know for some of these tendons, more than one treatment is probably needed. So the next randomized controlled trial was in March 2011. This was published in AJSM, and it was a double-blind randomized controlled trial, and it was looking at PRP for lateral epicondylopathy. Can someone mute if they're not muted? It's just I can hear an echo in my background. I don't know who it is. Okay, I'll keep talking. If not, I can go to the thing and try to mute it myself. So this was an interesting study because there was corticosteroid versus PRP for lateral epicondylopathy, and they gave an injection, and then they followed them out, and they excuse me, and they found something they call this crossover effect, where what happened was right between 8 and 12 weeks, it was a crossover where the first 2 weeks after treatment, the corticosteroid group did well. And then after about 8 weeks, the corticosteroid group started doing worse, and the PRP group started doing better, and they crossed over right somewhere close to 12 weeks, and then they continued with that PRP group doing better all the way out to 2 years out, and the corticosteroid group, obviously did not. So you can see very meaningful differences at 6 months and then going out to 2 years. Very similar study protocol for glute medius tendinopathy. So if you look at PRP, the best evidence in tendon are for lateral epicondylosis and glute medius tendinopathy. Not quite as dramatic as a crossover effect, but initially both groups do pretty well here. The PRP group actually did better off the bat, but then over time, the corticosteroid group levels out and the PRP group continues to get better. In this case, the better is the higher number here. You can say it's the same thing here. So real quick, I'm going to talk about tendinopathy and corticosteroids. So why do we use corticosteroids for tendon pain? So this is based on more an anecdotal culture habit, personal experience, and tradition than on evidence-based practice. It's been used for over 60 years, but the evidence is pretty bad. And not only that, there's actually evidence suggesting this could be harmful. And so if you look at this study, this was in Lancet in 2010. Brooke Coombs did this work, and it's a review of all the injections looking at tendinopathy and corticosteroid. They compared to multiple things. And the bottom line from this study, and there are 2 slides worth here, if you looked at all these studies comparing that corticosteroid injection is beneficial in the short term, but maybe worse than other treatments in the intermediate and long term. So we're saying that it's sometimes better to do nothing than to inject a corticosteroid in the medium or long term. But if you want to be able to feel better for a few weeks, then a corticosteroid, certainly could be helpful for that situation. Another review, 2011, said the same thing. It's helpful in the short term, but harmful in the longer term. They're a little more forceful in the fact that they say harmful in the longer term. And then in 2013, this is when I officially stopped using corticosteroids for most of my tendinopathies, certainly all my insertional tendinopathies, like lateral epicondyle, medial epicondyle, and insertional Achilles and patella tendons. this group, they compared a corticosteroid injection in a group of people with physiotherapy to a group of people who also had nothing done at all, just placebo injection. And what they found was at 4 weeks, once again, corticosteroid injection was favored, but at 52 weeks or at 1 year, the recurrence rate was much higher in those who got a corticosteroid injection than those who had a placebo injection. So you're more likely to have a recurrence of your pain in a year if I give you this corticosteroid injection than if I give you nothing. So, and that's what I tell my patients as well. So despite this, this article was a couple years ago and looked at fellowship-trained upper extremity surgeons on mild epicondylitis treatment, and they had 612 that completed the survey, and it asked them basically how do you treat mild epicondylitis, and you can see that the vast majority use things like NSAID and corticosteroid injections, which we know are not helpful and potentially harmful, and very few use things with like PRP and 10X, which is a debridement device that you may have heard me talk about before, and whole blood or saline injection, all of which have way better evidence than corticosteroids do, but much less people use them. So it's not changing quickly. Even in 2020, I would say that's still the case. Let's get that. So does PRP work? Well, I've been kind of talking about this since 2011. This was a slide I made, almost 10 years ago. And, the argument I always say is, it's not a simple question that does PRP work or not. That's like saying, does pick your antibiotic work for treating a sinus infection? Well, how do you know the answer to that if you don't know, what the drug is? You don't know how much of the drug you're taking. You don't know what the dose should be. You don't know how many times a day you should be taking it. You don't know for how long you should be taking it, or if you should be getting multiple ones. And so does PRP work? It's just not an appropriate question in 2020. We need to be talking about, is it, leukocyte-rich PRP? Is it leukocyte-poor PRP? Is it activated PRP? Is it done with ultrasound? How do they rehabilitate? We need to be very precise in the way we define this if we're really going to get to the bottom of some of these questions. And so I've been talking about this for a while. This is a classification system we put out in 2015 called the PLRA classification system, where we kind of talked about a new way to classify PRP. We were the first classification system that included red blood cells in it. We also thought that the platelet volume was more important than the platelet concentration. We want to know how many platelets were actually injected. Since this time, unfortunately, there have been many other organizations that have put out consensus statements and new guidelines. I shouldn't say unfortunately, you can look at it either way, but the downside is that we haven't had one that's been really adopted by everybody. The orthopedic surgeons put a group together and they came out with their consensus recommendation, which was very similar. In the blue highlights here, pretty much everything the PLRA talks about is in here. They talk about a few more things you should be doing in your research design if you're going to be publishing on PRP. But the bottom line is the same, that we need to be actually, letting it be known what we're actually injecting here. And then I published my first paper on PRP in 2013. At the time, we had 180 responded, and so we published, an N of 180, which I think equaled about all the PRP in the literature at that time. And so we had the biggest N for a very short period of time. We had the biggest number for a few months. It was retrospective data. It was folks who had pain for an average of 3 years. Their average age was 48. They've been through a bunch of other treatments, and the PRP was done with ultrasound guided. We looked at this as a multi-center. There were 4 groups who really did it. Some of y'all probably know Dr. Malenga, Dr. Borgstein, and then Dr. Harmon, who's out in Seattle, were the 4 kind of clinics where we looked at this. We looked at multiple distribution of tendons. The 4 most common you can see here. And overall, if you looked at folks and you see how they did afterward, 82% of patients reported at least 50% improvement in their symptoms. So they got at least what I would call moderate improvement, which is technically a good outcome. And 70% reported at least 75% improvement in their symptoms, which should be classified more as a great outcome. And so this is kind of how I still report to my patients when I'm looking at most of the tendons that I treat. Their pain scores decreased by 74% in the study. So, that could lead you to ask whether it's the needle or not. And so I mentioned we held the largest N for a few months. That was until this paper was published, which had 230 patients in it. It was a multi-center. They had 12 centers. double-blind, prospective, randomized controlled trial. And they were asking a simple but very good question of, is it the needle or is it the needle plus the PRP that's actually doing the trick here? And so their control group just got a needle penetration of the tendon, and the PRP group got a needle penetration with PRP. And you may be thinking, boy, those numbers don't look that good, because I had shown you earlier success with needle tenotomy at 80% or 90%, and PRP data at 80 or 90% as well with lateral elbows. But this study, they did not use ultrasound guidance, and so I think these numbers are artificially lowered, although it's probably still a good comparison without ultrasound guidance. And you can see, percent of patients are actually reporting significant elbow tenderness in the PRP group at 24 weeks with 29%, control with 54%, and so significantly better. Here it got statistically significant, and then maybe more so at the 6-month mark. And then they have a couple of meta-analyses over the last few years looking at this, basically saying there's good evidence to support the use of a single injection of leukocyte-rich PRP under ultrasound guidance of tendinopathy. I will say that I don't really agree with the leukocyte-rich part, although most of the data has been done with leukocyte-rich, and we can talk about this later if y'all want to or not, but I believe that actually leukocyte-poor PRP, where you take out the white cells, may be more effective for tendinopathy. But this analysis did not support that. And then lastly, this was another good systematic review of tendinopathy. And it basically looked at all the studies out there in tendinopathy that were available at the time that they thought were good studies. And they did this, what they call a once removed analysis. And basically, the once removed analysis, they took out like the best and the worst study and they combined the rest. And they basically found that PRP is more effective than control injection in patients with symptomatic tendinopathy. So my point with all this being that people often still come at me and come at some of us who are saying, well, there's no evidence for PRP that it works, and that's just not true. We have lots of studies now, really good studies. They don't all show success. Plenty of them don't. I could have given you an article that talked for the last 20 minutes about how PRP doesn't work and showed you studies, but the overwhelming evidence now is pointing to PRP does have a therapeutic effect, but we still need to figure out exactly how it works and how to optimize it. So another big interest of mine is talking about how to rehabilitate after these injections. And so this is another area of research that I just want to kind of point out is that, I published a few papers on this, but once you get the PRP injection as a, physiatrist and pulmonary doctor, I'm also interested in how do we best optimize, rehabilitation, immobilization, motion, strengthening. And if you look at some of these papers, I have a couple of rehab protocol published, especially this paper, here, which I think is a pretty good idea about what I do. But the truth is, a lot of papers don't report their rehab very consistently, and so it's hard to really know what's going on out there right now. So I'm going to shift over to arthritis now and talk about PRP for arthritis. Anyone have any burning questions right now, or if not, I'll just keep going and we'll wait to the end.
Keep going, Dr. Ken. Just keep going.
Okay, perfect. All right. So, and I will get to stem cells as well. So what is the role of PRP in osteoarthritis? So the pathophysiology of osteoarthritis basically says that, if you think less about arthritis as being this inflammatory joint condition, you think about it more as a balance of cytokine-driven catabolic and anabolic processes, which, if left unchecked, will continue to cause damage to a joint. And that degradation of the cartilage will lead to stiffness, loss of mobility, swelling, and pain. And so on a cellular level, you see downregulation of IL-1, IL-4, 10, 13, and some of the growth factors that cause this degradatory effect inside the joint. So if you think about it, if you have this downregulation, you take a biologic, and the biologic has interleukin-1 receptor antagonist, and it increases these growth factors and anti-catabolic, it will hopefully, and this is how it works in my opinion, neutralize this down-regulatory effect and create basically a better homeostasis in the joint, so the joint will be less painful and will be less inflamed. So, does it work? Well, once again, difficult to compare a study, different types of PRP, everyone's PRP is different, underlying arthritis is different, lots of different protocols out there, different rehab protocols. So what does the research say? Well, this is a study looking at JBJS review, meta-analysis. It looked at basically simultaneous treatments of all the different treatments out there for knee arthritis. Looked at 10 studies and looked at all these different treatments from acetaminophen, glucosamine, corticosteroid, HA, PRP, NSAIDs, pulse stimulation, and basically of all these things we looked at, PRP provided the greatest treatment effect. So it's pretty good, right? Of all these things that we looked at, PRP was the most effective. But certainly there was more room for research needed based on the conclusions. So in the last few years, there have been multiple studies, at least 11 that I can think of, maybe even more, that have compared PRP to typical things you treat arthritis with, like hyaluronic acid, which is still pretty popular in the US. In June 2018, it says mild OA, PRP is effective or may be effective as an alternative treatment. Another one said, compared with HA and saline, the PRP may have more benefit in pain relief and functional improvements. And then another one said, patient with symptomatic knee OA, PRP injection results in significant improvements up to 12 months post-injection. As I mentioned, there have been at least 11 studies comparing PRP to HA, and 9 of the 11 studies, PRP was superior, and the other 2, they were equally effective. So the type of PRP matter, I mentioned this a few times, in a knee arthritis, there's pretty decent data that it does, although we don't have any direct head-to-head studies. But basically, Brian Cole, who's a really well-known orthopedic guy in Chicago, and his group, they compared all these studies that use like leukocyte-rich or leukocyte-poor PRP, and they found that leukocyte-poor PRP actually had better outcomes and less adverse events than leukocyte-rich PRP. So, as I mentioned, the overwhelming evidence is in knee arthritis. The hip and ankle studies have shown improvements in pain and function. A lot of the smaller joints don't have really good evidence behind them. Although, anecdotally, I can tell you, I do a lot of CMC joint arthritis. I do some MTP arthritis, and we do get clinical success in most every joint that we treat. But a few things about PRP. It doesn't grow new cartilage. It can't reverse bony changes, so it's better to treat it earlier on. Even though it can't reverse bony changes, I think it does have the ability to prevent or delay progression of arthritis. OA is difficult to treat after you have bony changes. We know that. So it is ideally better to treat earlier versus later. So this is much more effective treatment in mild to moderate arthritis. And I mentioned this before, but studies indicated efficacy around 12 months of treatment. So what about corticosteroids in OA? Once again, similar to my story with tendinopathy, this was a meta-analysis that looked at 5 randomized trials with 312 patients comparing intra-articular steroid injections that relieve pain in OA. And basically, if you look at this and you look at the time out from when these were looked at, this is pain and function. The first week corticosteroid injections help with pain and function over most things they would compare to. But even by 1 month, most of those results are gone, and there isn't much difference in pain compared to other treatment options. We also know that almost all the steroids we inject into joints have dose-dependent deleterious effects on cartilage morphology, histology, and viability. So these corticosteroids, especially the particular ones, are toxic to the cartilage. And then this study in 2017, actually, they gave folks a corticosteroid injection or a saline injection every 3 months for 2 years, or 4 times a year for 2 years. They looked at the pain and function score, and they also looked at the cartilage after 2 years. And not only did they find that in the PRP group, in the corticosteroid group, the cartilage scores were worse after 2 years, but they also found no statistical differences in pain relief. So saline is really not a control. Saline has a positive effect on the joints. And you may want to think about it as an alternative to steroids, or I usually use a low dose of corticosteroids with some saline when I'm injecting to my joints. And lastly, all these anesthetic agents we're putting into joints, especially bupivacaine, which is Marcaine, or lidocaine, or xylocaine, are very toxic to joints. Ropivacaine or Nerapin is the least toxic cane to inject into a joint. And so We need to be careful about this. If you're using lidocaine or bupivacaine, but especially lidocaine, I don't use any more bupivacaine. You should be diluting it out to reduce its chondrotoxicity. All right, so the last kind of third of my talk is, moving on to kind of stem cells. And so, I've talked a lot about PRP and biologics. I went from prolotherapy to anatomy to PRP, and now we're going to get into this whole kind of concept of stem cells, which is really interesting to talk about. Searching for the fountain of youth is nothing new. This is showing a picture of two mice that were sewn together, something called parabiosis, which was actually first invented in like the 1870s, and it gained some popularities in the 1960s and 70s. And what they found was that if you sew these two mice together, their circulation will commingle, and so the old mice will get some of the blood from the young mice, and the young mice will get some of the blood from the old mice. And when they sacrificed these mice and they looked at them, they actually saw significant changes in the mouse morphology. And so the older mouse had younger teeth, younger hair, and yes, younger cartilage actually. And so the idea that we could take someone else's cells and inject them and reverse some of the aging effects, obviously the $billion idea, which we're still trying to harness. So what is a stem cell? So basically, we're talking about mesenchymal stem cells today, and as opposed to embryonic stem cells or the induced pluripotent stem cells, or we'll talk about a couple others. But mostly, we're talking about MSCs or mesenchymal stem cells, and they have multiple things. And so in medical school, I was taught that stem cells, they self-replicate and they differentiate into multiple tissue types. And that's true in test tubes, but in real life, MSCs reduce inflammation and they fight cell death. And this is probably the mechanism by which they work in our procedures. And so much like PRP, they have a lot of what we call trophic effects on the local cell environment, which helps to do all of these things. And they help to do it by supporting a lot of the growth factor we've already talked about today. There's also evidence out there, which I don't have here, that MSCs have a direct effect on opioid receptors and pain receptors, and may help people that way as well. So this is why, Arnold Kaplan, who coined mesenchymal stem cells in the early 90s, is now asking for this to be called medicinal signaling cells. So these are not really stem cells; they are signaling cells, and they signal these effects on the rest of the body. So what are the types of injectable MSCs we use for in orthopedics? So here to list. I use almost all autologous. I'm going to spend a couple slides talking about allogenic products. Bone marrow aspirin and bone marrow concentrate is really what's allowed in our country. Anything that's cultured and expanded, you can't do in this country unless you have permission from the FDA, which is our regulatory body. Some other countries have less restrictions, but that's generally true. With adipose cells, you can do a fat graft or lipoaspirate. And for the most part, there are ways which that is pretty much seen okay by the FDA. I say pretty much, there's a little bit of a gray zone, but I do believe it's okay the way we use it. But once you start using enzymes to digest the fat, which is what SVF is, or once you start culturing and expanding the fat, all of a sudden you're doing what they call more than minimal manipulation. And that is considered creation of a new drug, and that needs to be regulated by the government, so you can't do that. And then you have the allogenic product, which I'm going to actually talk about right now, which are very much in the gray zone. So when you're talking about the birth tissue product, I just want you to be familiar with the term, because they all come from different parts of the birth tissue. Some are made directly from the amniotic fluid. Some come from the amnion and the chorion, and they are homophilized, or they're freeze dried, so they come like a powder. And the more popular ones these days are usually part of the umbilical cord, and so you can have umbilical cord blood. You can have Wharton's jelly, which is basically the inside of the umbilical cord, or you can make something called this is cord tissue, mesenchymal stem cell, human cord tissue. So they're basically taking cord tissue, the whole thing with the inside and outside, they're cutting it, they're mincing it, and creating an MSC product out of that. So the big debate about these MSCs is, are they alive, right? I mean, are there live stem cells in these products that at least in this country, are kind of hawked as being, a way to treat orthopedic conditions. So there's two ways to answer that. Number one, are the live cells? Number two, are the live cells functional, and are they vital, right? Meaning you can have a cell that's alive, for example, this person and this person are both alive, but one of them is healthy and one of them doesn't appear to be, right? And so if you're just doing an assay where you're looking at alive and dead, these are both going to be considered the same state. And so as someone who works with some of these tissues sometimes in the lab, a lot of these things, even when we get high cell counts, when we examine them a few minutes later, the cell counts are lowering because they're actively dying over a short period of time. So here's my overview of these birth products. I've done very little orthopedic studies on any of these birth tissue products. Aggressive selling, and I'll talk about this at the end of my talk, in these stem cell clinics, which is where they're used a lot. Multiple independent studies that demonstrate very few or zero live or functional MSCs in their products, despite the manufacturer's claim. In November of this year, companies will be at the end of a 3-year window where they need to better study these products. In the past, they could get approval through a very quick, at least in this country, my country, in the USA, through a very quick 45-minute online application, and they can start selling product. But they're going to have to be more rigorous going forward to stay viable and alive. So also some of these companies, I'll talk about Lipion in a moment, have had GMP issues as well, and have had issues with manufacturing, and have had really sick patients as well. So having said all that, despite the fact that there are few or no live cells or functional cells, there are growth factors in the products, and they might have a therapeutic benefit. I'm not saying they're of no value whatsoever, but they're not a stem cell treatment, and we shouldn't market them as so. All right, so actually I don't need the volume on here. So now I'm going to talk a little bit about my first day doing BMAC. This is the patient. This is not the patient. This is just a video showing my BMAC procedure of how I do it. But this is the bone marrow aspirin procedure, and this is I had two patients on my first day: a 37-year-old female pain doctor and a 67-year-old female. And so the 37-year-old female pain doctor who lives in Atlanta is kind of a friend of mine. Was the first one I did, and I went in, I numbed him up, and I started doing these taps on the hammer and doing this kind of stuff. And he was in screaming, agonizing pain. I was sweating bullets, and we had to abort the procedure. Just couldn't take it anymore. So I'm freaking out. But then I have this second patient who's come in the same day, who knew it was my first day and was okay being my second patient. And I did her procedure, and went like clockwork. She didn't flinch or whatever. And he came back a couple of years later after I had done about 100 or two, and we did his successfully. As we do this procedure, you can kind of see some of the steps I take where we're kind of moving things around. I like to go to multiple spots. We want to sample multiple areas. The more areas you sample, the more fresh MSCs you can obtain. There are different ways to get into the bone. I like the mallet approach. Some people use a drill, some will just use their hand. But the mallet can get you in pretty easily. And then after you take a syringe, you take these slow, quick pulls from the syringe, hopefully the hand will move away. But you want to bring it up and have some pretty light air bubbles in there too to kind of help you bring out more of the cell. So there are definitely some techniques to learn with that. So this first patient who I ended up doing, it was for her tendon, because this is a long time ago when tendinopathy that I treated more of. And you can see this is her lateral glute tendon. You can see the T2 and the T1 picture, the thickening, the little partial tear. And then 4 years later, I did another MRI of her tendon on her joint for a different problem, but I looked at the hip again, and once again, look how much better the tendon looks than it did beforehand. So that was improving. She did really well with the procedure. So I won't belabor this point about doing no harm, but these have been looked at through multiple thousands of case series by Crisanteno, as well as here by Hernigu. And they have basically found, the initial fear was that if I put MSCs, I take the bone marrow, put it in your shoulder, I'm going to grow tumors in your shoulder. But in a same-day bone marrow aspiration procedure with no culture expansion, they have this has been shown to be extremely safe, with no increased risk of carcinogenesis at the local site or systemically, compared to patients who didn't have this done. This has also been looked at for adipose-derived cells and SVF, and culture expanded MSCs, and once again have been shown to have no significant adverse events. So safety is pretty well tolerated in these autologous, procedures. And I've never had an infection or any sort of complication major in my adipose or bone marrow procedures. So what did the evidence show in 2020 on using signaling cells or stem cells or MSCs in the musculoskeletal system? Well, the only really high quality evidence is for pre-collapse AVN. Philip Carnegie's done a lot of that work. If you can get AVN before collapse of the vascular necrosis and inject stem cells directly into the AVN, you can actually get reverse the disease process. Knee arthritis shows case reports and case series with favorable results for BMAC and what we call micronized fat, which I'll talk about more in a minute, as well as stromal vascular fraction, which we can't do in the US. I mentioned before that evidence for regeneration is lacking, especially in non-culture expanded MSCs. And so most of what we do in the US is non-culture expanded MSCs. And so I still don't promise people that we're going to get any kind of regeneration. And so this is really probably working through those secretory pathways, not to differentiation. So it's not a curative treatment, but it is a palliative treatment. It can be for quite some time. So, what is the optimal source of MSCs? This has been an interest of mine for a while. It's been looked at in multiple studies, looking at different ones, but most studies only look at one product and they don't really compare products. And so it's hard to really get an answer and compare data. And no study had looked at it clinically, comparing one to another. And so I published a paper last year looking at the MSC source and does it affect the outcome, adipose versus bone marrow. And this was just looking at patient-reported outcomes in the two procedures. I had 76 patients who had follow-up data. About half were micronized fat and half were bone marrow. I had at least 6 months follow-up in both groups. I already showed you my bone marrow technique, so I'm just going to show you here versus my lipoaspirate technique. And so as I'm going in here, we are getting out. So this is a kind of a compilation video here. So we're getting out the fat here. After done getting it out, we put it through this filter. We put it into this device here, and we wash it. We filter. We rinse all the blood out of the fat. And as we do that, we clean it, and then you'll see in a second we use these ball bearings to kind of help break up the fat. So we're allowed to reshape it, we're allowed to rinse it, we're allowed to resize it. You can see us doing all these things right now, and then we're left with a much clearer product. And then when we're done, we put it through these filters at the end, and we get what they call glycogen, which is a micronized fat product, and then we inject it into the body. So I injected either 8 cc of bone marrow and 9 cc of micronized fat. And if you look at my outcomes, they were the same. So both groups did well. They did equally well. The one did not do any better than another. So then I went back and looked at my data, and I said, how did the responders do? So if I took folks who responded, knowing that there's going to be a percentage of folks who get no relief from this procedure, right? Let's take them out of the mix. We know they're not going to get better. But look at those who do get better. And if you look at those who responded, there was about a 73% reduction in their pain scores, slightly better in the bone marrow than the MPAC group, but statistically didn't make a difference in the two. Much more positive results if you just took out the folks who didn't respond at all, which is really the way I talk to my patients about how these procedures do. And then if you look at the degree of arthritis, as you got to more severe Kelvin-Lawrence scales, 3s and 4s, it was honestly 50-50 if they had success or not, where the 1s and 2s did significantly better. And so once again, that's something you can talk to patients about, 50-50 chance with the severe knee arthritis of actually getting any relief or getting significant relief. Now this was looked at least 6 months later, so some of them may have gotten a little bit of relief, but it didn't last for at least 6 months. In hips, the numbers are even worse, looking at the grade 4s. So I mentioned significant improvement in pain and function with MFAT or BMAC in patients with knee arthritis without a significant difference between the treatment modalities. I mentioned it was at least 6 months out, but it ended up turning out that the average follow-up for the MFAT was a year, and the BMAC was 1.8 years. And then there were some patients who, did seem to get, you can see the inside of this patient's knee that does appear to be widening a year later. Once again, I never promise any regeneration to occur, but we do see folks who have significant changes in their X-rays or MRIs where we can get them. So how long did it last? So this is the study that's out there. We're actually publishing a study on this with a few other folks, which will have closer to 200 patients in and looking at 2 to 3 year follow-up. But in this one, at their 3-year follow-up, 22 out of 30 maintained the therapeutic benefit. So 2/3 are still doing well 3 years after the treatment. So that's pretty good. So, I mentioned that the part of my talk being the Holy Grail, and this study is kind of my Holy Grail. So this is a randomized multi-center trial comparing the efficacy of multiple stem cell preparations, one from bone marrow, one from adipose, one from umbilical cord tissue, and there's a control group of corticosteroid injection in this study as well. And we got a $13 million grant from the Marcus Foundation, and we are the leading site for this study, which has been going on now for about a year. We're not only we're going to be doing a screening exam, we're doing blood work, we're getting X-rays, we're getting MRI, cartilage mapping, and then the beauty of this study is we have these 3 different arms, and in each arm, a quarter of the patient are going to actually just get a corticosteroid injection. And so we get patients who are doing a bone marrow aspiration, but then we're just injecting them with steroids, and they don't know it. They're blinded, and we get patients who are having a fat aspiration, and then we're just injecting them with steroids, and so they're truly blinded as to not have any placebo effect bias our results. Not only are we doing the different injections, but we're also doing cellular analysis of the patient's synovial fluid, and we're analyzing everything we're injecting. So we're sending it off to Georgia Tech, where they're doing very high level viability and lipidomics and proteomics and things I don't even understand, looking at different things with these cells. And so, not only are we going to see what the levels of arthritis do for this, but we're also going to see are there dose responses to these products, and I think we're going to get a world of information whenever we finish this. And then we're going to be following these patients for 12 months with 3 MRI and patient-reported outcomes and a clinical exam of their knee as well. So March 19th, we were at 220 enrolled out of 480, and then COVID-19 hit, and we've been suspended, but we just got to go ahead to start seeing patients back, I think, next week, basically, and later this month, we're going to start to resume treatments, and so we'd hope to finish enrolling by December of this year. Now it might become mid next year with COVID, but we are on our way, us and all the other sites that we're working on. All right, so I got my last bit of my talk here is talking about, where is regenerative medicine headed? So this will all kind of get a little more philosophical here, and hopefully y'all are all still awake. It's early for you, late for me. Hopefully I'm still awake. Everyone has a story, and so I had a poor patient who came in, 71-year-old male, had low back pain, neck pain, shoulder pain. He came in for a stem cell consultation for the shoulder pain. My advice was I wasn't gonna, do any stem cells on him before I had more advanced imaging and MRI or ultrasound so I could see what was going on. However, his pain was worsening, and so he went to this stem cell clinic, which I don't like to name who they are, but you can read. But y'all don't live here anyway, so you don't know them, but they're very nefarious. They were treated with umbilical stem cells. Basically, he had them done 6 facet joints in the cervical spine, 4 facet joints in the lumbar spine. They were ordered by a chiropractor, referred by a retired general surgeon. He's no one who I know. I don't know if they know what they're doing at all. And then 3 spots in his left shoulder were injected with no guidance, and this was done by a nurse practitioner. He paid $20,000 for the procedure, which is the first thing that's bad. Came to see me 3 to 4 weeks later with worsening pain. Couldn't even lift his head to neutral anymore. His head was just in a tilted down position. He was in agony. Couldn't lift his shoulder overhead. So I wasn't seeing him for his neck and his back. I was just seeing him for the shoulder. So I got out an MRI of his shoulder, and basically he had horrible metastatic cancer. not caused by the injections, which were just done 3 to 4 weeks earlier, but no one bothered to work this up. He was in a lot of pain, paid $20,000 for a procedure, and he has, stage 4 cancer, and with $20,000 out of potential other treatments he can pursue for that. So very unfortunate stories. These things are all over. They have literally they have these Winnebagos that you can go and get your stem cells in. They have this guy who called themselves the Regenerative Warrior. They have this company that talks about the first line of the website talks about their profit margins, about partnering with them. I mentioned the story of Livion. If you haven't listened to the podcast called Bad Batch, it's pretty good. It talks about the whole thing with Livion, and not only this is a amniotic or birth tissue product, but just in terms of all the patients get really sick and all the shortcuts that the company appears to take, trying to get to market and not really taking some of these things seriously, and how they're still kind of, in my opinion, in denial about it. You have this website that talks about success rates of 99%. This is once again one of these local stem cell clinics. 97 to 99% of patients went from a 10 to 0 in the pain scale. 2 to 3% went from a 10 to 4. So basically, everyone gets better, and I don't know why all these patients have 10 out of 10 pain. They all go to 0. Just totally BS. But this is what they sell you when they bring you into their little webinars. And if you look at folks and you look at who are doing these procedures, about 30% of people in this list are not medical doctors, they're not osteopathic doctors. There are naturopathic doctors or chiropractors who have other degrees. I'm not saying they can't do an injection, but I will say that they may not have the level of training, nor they may be equipped to deal with some of the complications of some of these procedures. 2019, Google banned ads for unproven medical treatment. So basically they said you can't use the word stem cell on ads anymore, which I get why they were doing it, because they were trying to, kind of deal with this whole population of folks who are using this for, getting money and not really for legitimate purposes. But they're kind of lumping everyone together, which is my whole point with this. Everything is that people like myself who do research and try to promote the responsible use of these products are being lumped in with these people who are, charging $20,000 and not really doing a good job for the injection where it should go. So, and then this is interesting too. It talks about, my title, why is cellular medicine being held to a higher standard? People talk about some of these articles with cellular medicine where there's a non-response rate, and if you look at everything in medicine, there's a non-response rate, right? I mean, anti-inflammatory only have about a 60% response rate. Some of the HIV vaccines out there are 30 to 40% response rate. And so if you go into thinking, okay, well, 30 to 50 or maybe 60% of folks aren't going to respond to this treatment, and people understand that, maybe then you can have an honest conversation about, that expectation. Having said that, the goals of what I'm trying to do, a lot of us around the country, around the world, are trying to optimize these procedures, who are, so that we can reduce our non-response rate. So we're trying to optimize the MSCs we injected. We're trying to optimize the characteristics of the joint, which one will respond the best and which one won't. I hope there's a time when I fluid out of a joint, look at it, or analyze it in the lab, then make a cocktail that will treat that person with this precise, cocktail of cells. So we can kind of, get those numbers down. So my last slide here, just at an hour. So there's lots of gaps that still exist in regenerative medicine. We talked about the trophic or secretory effect of MSCs for treatment of musculoskeletal condition. We talked about the difference in the mechanism of action in soft tissue versus cartilage disorders. We talked about trying to translate some of the in vitro lab analysis to clinical practice to optimize the precision of these products. That's what I was just talking about before. But as I mentioned earlier with PRP, we still know the optimal source of cells, the optimal dose of cells, the route of delivery. I didn't even talk about scaffold and hydrogelatin carriers and other things that we looked at to increase the residual time of the cell inside the joints. And then when I'm interested in rehabilitation of cartilage and tendon disorders and how that can impact healing as well moving forward. So that's the end of my talk.
Thank you, Dr. Ken. Thank you very much for
it's raining really hard here, so if my power goes out, I apologize, but I got through the talk, so that's good.
It's okay. So anyone who would like to raise your question, please ask directly Dr. Ken.
There are a couple I see. I can also look here in Q&A.
Okay.
So there are a couple that people did put in. There we go. Yeah, for AVN of the femur, do you recommend MSC injections into the hip joint or injected after bone drilling? So I don't do intraosseous work, but if someone has pre-collapse AVN, I'm going to send them to colleagues of mine who do that. I do think you have to drill directly into the femoral head and get the medicine to the site of the lesion. I think under fluoroscopy, not ultrasound, is the best way to deliver the medicine to the area. Do you have to do a traditional surgical retrograde drilling, or can you just go in with your trocar and inject? I don't know the answer to that, but I think you can probably just go with your trocar and inject the MSC to the femoral head and probably get the therapeutic response that we're looking for. Let's see if another one. Have you tried treating femoral acetabulum impingement of the hip joint? Oh, it's from you, Jim. Yes. So so what I'll say about FAI is, biologics can't treat mechanical issue, right? So if you have a bony prominence of a cam lesion or a pincer lesion or an associated labral tear, I can't treat those mechanical lesions. I may not be able to improve their motion, but yeah, I can definitely settle down the joints in people who have FAI. And so I have a lot of kind of 30 to 50-year-old runners who had some underlying FAI, they get an inflamed joint, and PRP can be quite successful, or MSCs in treating their symptom, but not curing their FAI. Just like we know a lot of people who have FAI, aren't really symptomatic from it at all. So basically, I'm just trying to calm down that joint irritation, maybe kind of work on that labral tear as well. I will inject a lot into the labral directly as well when I do that. So which stage do you inject AVN on the hip? So it's basically stage 0 and 1 before there's any collapse. How about sports hernia? How do you approach it with regenerative treatment? That's a good question, Jim. I think sports hernia, the way I treat sports hernia, which involves a lot of lower rectus abdominis and adductor longus pathology, those tendons come in kind of form a conjoint tendon right on that pubic plate. Those are the areas that I treat with mostly PRP. I don't use stem cells a lot in that area. My lights are flickering. I told you it's storming. I don't use stem cells a lot on that area, but in PRP, I find it extremely successful. I've been doing that for a long time. There's not much literature out there on it, but I have lots of young folks who I used to send a lot of people for sports hernia surgery. And since I started using PRP, I rarely send anyone for surgery anymore. So I think it's a great treatment option. Another question, is your experience for knee arthritis was superior, PRP or BMAC and lipogyms? So it's a good question. I don't know. There was a paper that just came out a couple months ago that my colleague, Dr. Hackle, was a co-author of, which they had a study comparing PRP to BMAC, and their 12-month data didn't show any difference between the two. And I think there may be some technique reasons why that is. But what I counsel patients and what I tell them is I think the same amount of folks, so say 75% of patients will respond to PRP or respond to stem cell. But I do think if you're doing a cellular procedure with BMAC or lipogyms, you're likely to get a more robust response and the response for longer. So where PRP, the data shows up to about 12 months of successful resolve, I think for the BMAC and lipogyms, 3 to 4 years, they don't have severe arthritis, it is pretty realistic. Some people are combining PRP with other treatments such as HA or even with physical therapy such as shockwave. Would that be more effective? Boy, y'all are asking really good questions. So there is data out on this. For knee joint arthritis, there's 2, I think maybe 3 studies now suggesting that PRP with HA is better than either one alone. So I have 2 ways I'll do that for the knees. Sometimes I will combine the 2 in the knees. There's one study looking at the hip which showed it wasn't better to combine them. So I'll either, sometimes we'll combine PRP and HA in the knee, or I'll do an HA injection, and then about 3 or 4 weeks later, if they're not feeling better, I'll then do a PRP injection into the joint. So kind of get that synergistic effect of both of them, even though you don't put them in at the same time. Can you share your protocol preparing good PRP when the site better in the tendon for good results in dosage? So I think what you're asking, so almost all the PRP I prepare is, leukocyte or PRP. So I use the double spin method, which I didn't really go into. And so I use one of the commercial products out there. I don't want to promote any product particularly, but I like products that I can double spin. I like products where I can remove white blood cells, especially the neutrophils on the product. And I like a product that I can kind of manipulate the platelet counts. And so there's some things that I want a higher platelet concentration and some things that I want more poor plasma or lower platelet concentration to do. I actually have a paper that I just submitted for publication, which really talks a lot about this, and it talks about what might be that ideal range for each different site of how much we inject. We don't know is the one answer I could give you. But in general, for cartilage, I like something around 1.5 to 2 million platelets per microliter. And for tendons, probably can get away with a lot less in a tendon, maybe 1 million to 2 million. It might be the ideal range for that. Would you recommend PRP post-arthroscopy or post-surgical? It's kind of a loaded question because the data's been mixed. If you look at PRP combining with surgery, and the rotator cuff has not been really shown to be a benefit, and so I would say no, I don't recommend that. Can y'all hear that rain in the background? It's really loud. I'm in a room with a lot of windows too. There are some studies. There's one study looking at the hip where they did PRP during surgery, and they found that they had less pain and quicker recovery from surgery with the PRP. What I will say in terms of after surgery, that there are patients, especially with knee arthritis or degenerative knees, where sometimes they'll have something mechanical going on in the knee. So they'll have like a desensitized meniscus tear or some loose bodies or some other things. And yeah, I'll have the surgeon go in there and debride the knee. And then I'll come back about a month later and inject a biologic into the joint once it kind of calmed down the joint. So, it's kind of like, before you paint the road, you want to sand the wall. So I think sometimes that could be beneficial, but there aren't a lot of studies looking at combining the two in that way. How soon do you do it after surgical procedure? So, yeah, that's a good question. I tend to wait. Some people like to do it during surgery or immediately after. I tend to wait for about 4 to 6 weeks for a couple reasons. Number one is I want the holes in the joint to heal up. So if you did it arthroscopically, I don't want it leaking out the holes so the capsule's full. And secondly, I like to wait till they've kind of gone through that initial inflammatory phase and the joints kind of settle down. If you have an inflamed knee and you inject these products, I don't think it's going to work as well. All right, hold on. I'm still going through here. Lots of questions. What was I? How about barbitage with civic tendinopathy? Yeah, I mean, y'all are asking all the right stuff. I have talked on all this stuff. I talked for an hour already. So, I'm a big fan of barbitage with civic tendinopathy. I do some 10x occasionally too, but barbitage is still my go-to procedure. And it works really well in these soft kind of calcifications in these tendons. The question I usually get is whether to combine it with PRP, and I don't think you need to. Plenty of evidence out there showing that barbitage alone is very effective, and in my patients, almost always the tendon will heal after you remove the calcification. And so I've maybe done them together 1 or 2 times, but for the most part, I just barbitage them, and people do quite well, and it's usually a one-time treatment. You just got to give them 2 or 3 months to kind of fully recover from it. What is your recommendation for a PRP for the knee? How is it prepared? Range for minutes after T1 or 2. Well, I already talked about some of that stuff. So just to kind of go through a couple of things I didn't talk about that. I usually inject about 7 or 8 cc's into a knee joint. Yes, I aspirate before I inject. Actually, I think ideally, if you can treat these patients a week or 2 ahead of time and calm down the joint before that day, you're probably going to be better off, doing it that way anyway. So the big debate is about how often to do the PRP. So I do not follow a strict protocol where I'm going to plan on doing 2 or 3 of these, which a lot of the studies do, mostly because they're comparing it to HA injections. So I usually do 1, and then I reevaluate it in 6 or 8 weeks. So we're talking about both. So for joints, I do a PRP injection in the joint. I'll evaluate them either back in the office or by phone or now by telemedicine like 6 or 8 weeks later. We'll see how they're doing, and if they're pretty happy, we'll leave them alone. If they're still getting better, I'll leave them alone for another month. And if they feel like they're better but plateaued, I'll consider doing a second injection. It's usually only 1 or 2 for a knee, and they're good for a year or so, or they're not. If they don't get any response to 1, I don't think doing more is helpful. For a tendon, it's a little different because we know tendinopathy takes longer to treat. It takes longer to get better. So for a tendon, I'll inject the tendon, and then I will see them back about 6 or 8 weeks just to remind them that they're not going to be better yet. And then I don't think about repeating that tendon injection until about 3 months out. And in my mind, at 3 months out, if they're greater than 75% better, they're good. They're going to keep getting better. If they're between 25 and 75% better, I'll probably do a second one. And if they're no better or minimally better, I got to relook at what we're doing here, because that shouldn't be the case if we do it the right way the first time. Occasionally, I'll get a really bad tendon that I'll recommend multiple treatments for. All right, post-PRP injection for knee OA, how soon you start with physical exercises. So my protocol for knees, I usually have them rest for the first couple of days, but within a week, I'll have them start getting them to life and doing some light resistance exercises, some body weight type exercise, and maybe some range of motion type stuff. But really 2 weeks for any strenuous biking or heavier lifting, and about 4 weeks until I let them get back to any kind of physical activity, like exercise wise. Would you consider prolotherapy versus PRP with tendinopathy and intra-articular injections? So I don't do a lot of prolotherapy. Prolotherapy is great. Most people come to me for PRP or stem cells, so I have a very referral-based practice, so that's what I do a lot of. But prolotherapy is cheaper. I think it works well. I think it often requires more treatment. So specifically in tendinopathy, like I said, I think just putting a needle in the tendon works pretty well. So prolotherapy around tendons, I think, is very effective. Interestingly, they just had a study done that did prolotherapy, HA, and PRP in the knee at the same time, and they have results with that too. So we'll see where that goes as well. How do you approach persistent synovitis? Give me a ready rule or other causes. Yeah, persistent synovitis is tough. And I have some patients with it, but I'll tell you that in theory, the treatment I do for these patients, which I didn't mention, so it's a good question, is I'll do something called A2M, which is alpha-2 macroglobulin, for those who don't know that. So basically with A2M, I take about 120 cc's of blood instead of my normal 60 for a knee, and I spin it, and then I get rid of the PRP, and I get rid of all the blood, and I'm just left with what we call the platelet poor plasma. And then we put it through these filters to kind of get rid of all the water content, and we're left with about 12 cc's of A2M, amongst other proteins, which have a significant anti-inflammatory effects. And so for that type of knee, I would drain it and consider A2M in the knee, and that's probably been my most successful treatment. I would also say that bone marrow concentrate has a lot of something called IRAP in it. IRAP is interleukin receptor antagonist protein, which helps a lot with arthritis and inflammation. And so BMAC could be a good treatment for persistent synovitis, but I gotta admit, I get some patients who just continue to get infusions, and ultimately some of them go for synovectomy and joint replacement and other things. But the A2M is something I would look into if you haven't tried that yet. Thank yous. Thank you. A2M, he says for Cytonics. Yeah, I use a different. There's a couple of companies now that make A2M. Cytonics was the original makers of A2M, and a few different ways you can make it now, which kind of accomplishes the same thing. No one wants to ask a question out loud. Gosh.
Okay, I have a question. Just a little one.
Nice.
Have you encountered doctors who actually expose the PRP to some laser light prior to injecting them to the patient? Did you see any difference about the effectivity of a laser treated PRP rather than just the one directly injected after centrifuge? Thank you.
Yeah, great question. I actually do have one of these LED lights that I use for some of my intra-articular injections of PRP. And so the idea is there's a whole branch of medicine, called, kind of phototherapy, right? It's the same idea behind taking a jaundice patient and exposing to UV light and treating jaundice that way in a baby. And so this light, in theory, helps to activate the PRP and maybe has causes a little greater anti-inflammatory effects. So it produces more of this IL-1 receptor antagonist and some of the anti-inflammatory proteins to it. And so in a test tube, that's what it does. There's never been a comparison study showing it to be more effective than doing regular PRP. At least I've never seen a study with that. I've seen some studies that have used LED lights or laser therapy or different forms of light. But I will say that almost all the joints I inject, I do some photoactivation before I inject the joint. It's kind of one of my little tricks that I do, and I think it might help kind of get people better a little faster. Excellent question.
Yeah.
You have another one?
Any more? Dr. Ken, thank you very much. I cannot speak very well, but
yeah, Jim, why are you hoarse? I've been talking for the last
hour. I've been singing the whole time. I've been singing.
Late night last night, huh?
Yeah. So thank you very much for your time, Dr. Ken, and hopefully I'm gonna listen to you in Toby over the weekend. And
so originally I wasn't going to be at Toby because I was going to be doing this ultrasound course at Pittsburgh, and then since that got canceled, I'm only on a panel in Toby, so I usually give a lecture, so you won't see me that much. But I'll be up there for like an hour doing some stuff. So I look forward to it though, and once again, thank you all for having me. I love seeing you all's faces, or at least a couple of y'all's faces, and I miss you all, and it's so nice to kind of see y'all and see that you're doing well, and send my best to everyone else who's not on the call who I usually see.
Oh, Dr. Jeff was just in Messenger, and he sends his hello to you too.
Nice. Tell Jeff hi for me as well.
Yeah. Thank you, Dr. Ken, and be safe. Do you have any new book? Do you have any new book coming?
So I just agreed to help Jerry Malanga do a second edition of that regenerative medicine book that he did. He did it with Victor Ibrahim, and we're about to do a second edition. I said I would never do a book again, but he convinced me to do a second edition of this book. So
this one?
It's oh, I can't see it. Your background is covering it. It's the yellow one. I'm sure that's it though. I still can't see it. Yeah, there it is. Yes. So the second edition will come out in 2021. And then there's a new ultrasound injection textbook, which I'm not one of the main editors of. Yeah, the book that Pash has. But there's a new one coming out that I'm kind of an associate editor for. It's similar to the ultrasound textbook that I wrote before, but it also goes more into some of the regenerative medicine procedures than the other textbook, I think. So anyway, that'll probably be out next year too.
This one?
That one. I still love that book. Yeah, so it's not a second edition, but it's a similar textbook, and my name will be on that one too. But books are a lot of work.
Thank you, Dr. Ken. Thank you.
Bye, guys. Take care. God bless.
God bless.
See you later.
See you later. Okay, bye.